Okay. Hello, all. My name is Jade Woodridge, and I'm here with Miss Tanisha Dungy. We're welcoming you to our Women's History discussion on women's health and women's health disparities. With us are Dr. Karen Garcia, Dr. Elisha Johnson, Beatrice Orns, Tina Guajardo from Bronson Health, and Jermaine Jackson, of those of you may recognize from the Henrietta Lacks exhibit that we had at Willard last week. Today is also the last day to enter into our swag giveaway. If you are interested, just drop us a like or a comment on our video, and we will enter your name or record your name into our swag giveaway drawing. Now I will turn it over to Ms. Orns.
Good evening. I am really excited to moderate this panel of distinguished guests. My name is Beatrice Orns. I work with Bronson Healthcare System, and more specifically here in Battle Creek, my hometown. So it's a joy and a pleasure to be invited and to be a part of this wonderful women's history event that has happened in Battle Creek. So I have a few questions for some of our guests. I don't know, is it appropriate for you to introduce yourselves before we get started?
Would you want to do this popcorn style? Hello,
Yeah,
everyone.
please go.
Yes, I'm Dr. Elisha Johnson. I am the System Director of Business Self-Services for Bronson. I am also a psychotherapist by training, and happy to be here today. Thank you.
Thank you.
Hello, everybody. My name is Tina Guajardo, and I am a registered dietitian and health educator at Bronson in the community health department. So thank you. I am looking forward to our conversation tonight.
I could go next if you guys can hear me okay.
Yeah.
Okay, so I am Dr. Karen Garcia. I'm actually a pediatrician, work as a newborn hospitalist for the Bronson system. I'm also international board certified lactation consultant, and I'm incredibly excited to be here today.
Good evening. My name is Jermaine Jackson. I am from Kalamazoo, Michigan. I am the grandnephew of the late Henrietta Lacks, and I'm glad to be here tonight to be a part of this important discussion.
Thank you. And thank you all for joining us. So let's just jump right in. So I have a few questions that I really want to poll the panel to really get your insight on women's health and how it's been impacted historically and presently through a number of things. So one of the things that we know exists is a health disparities, specifically between women and women of color. So when you think about the types of health disparities that do exist, that we know have existed historically and that currently are major impacts on health for women of color, Dr. Garcia, what types of health disparities are you seeing? Do you come to mind for you as it relates to the disparities between women and women of color?
So I can start. I think one of the biggest things that we have to keep in mind is for women in general, cardiovascular disease, things that tend to disproportionately affect women across the board, tends to be identified much later, and the morbidity and mortality is significantly higher in comparison to men. And then when we start looking at women of color, there are different things that tend to be affected and impacted in different ways. So for instance, in Hispanic women, one of the things that we tend to see is that the rates of breast cancer and cervical cancer are actually significantly higher. They tend to be caught much later on, and so the mortality rate tends to be much higher. And then when we're looking at for instance, for me, working as a newborn hospitalist, working with mothers in that perinatal, that fourth trimester period, we've got pretty significantly elevated rates of maternal mortality for our Black mothers. We've got increased risk of postpartum depression, postpartum anxiety, and even with our babies having increased risk of sudden infant death or sudden unexpected death in childhood for children in the first year of life. And that's even after we're taking into account highest educational level and wealth and socioeconomic status.
Thank you. Um, Jermaine, what have you seen? What has been your experience when considering types of health disparities between women and women of color?
Well, one of the things I can speak from just from living in the community here in Kalamazoo, we know that we have a higher infant mortality rate with Black women in particularly, more than any other woman. And that has been a continual issue. And we are ranking, unfortunately, like one of the top places in the state for sure. I don't know how that measures on the country, but I know that in the state we have one of the higher infant mortality rates, and I know that exists for various reasons. But I also believe that there is a lot of racial disparities there, and I think there's a lot of roadblocks that exist for women of color and Black women specifically, and I think that there has to be more intentionality around recovering any disparity. I think what's the answer for any disparity is investment, research that's getting right down to the cause of why these things are happening, which I think there's an answer to that. So I think that there's the intentionality of making sure that that it's being addressed in order for it to recover. And I also heard our previous speaker mention about even like cancer, right? And so we know that even with cancer, both my mother and my grandmother are breast cancer survivors. But I will say that even with them, they went to the doctors, had complained about some different things that were going on with them. And even with them, my mother didn't get the proper diagnosis until she was at stage 4 with breast cancer. And so she realized when she used the services here that they weren't as keen as when she went to cancer treatment in the state of Illinois and she went to the cancer center. And they were very detailed and very, very specific about targeting where the cancer was, how it had even spread beyond her breast. And they also were strong critics to whoever had, looked after my mother prior to her coming to the cancer center, and said that they did a poor job of treating her. So there's just some things that I think, again, hospitals and those in the medical field have to become very intentional about fixing.
Thank you. And so it's a perfect segue because Tina works strongly within the community. So Tina, I want to invite your voice into this conversation as it relates to disparities between women and women of color. What has been your experience, and what have been some of the things that you have been able to recognize?
Thank you, Beatrice. Yes, and so I want to just compliment what Dr. Garcia was referring to as far as cardiovascular disease in women of color. As a dietitian in providing nutrition education surrounding cardiovascular disease or diabetes or weight management, we do know, we have the data from the Center for Disease Control that shows that, Black or African American, Hispanic or Latina females do experience, cardiovascular disease such as hypertension or high blood pressure, a diagnosis of maybe overweight or obesity at higher rates than white women in particular. And so, that is, Jermaine was referring to intentionality when it comes to these disparities, and the work that we do from the community health aspect and identifying these social determinants of health, as far as like food insecurity, which would pertain very much to, what I do as a dietitian. But we also see that a social determinant of health like food insecurity does play a large role for women of color and the increased risk of chronic diseases.
Thank you. So, and I think being an African American woman, many of the things that you have spoken about, cardiac disease, I'm a breast cancer survivor, and then having all of these things in my family. And then from Jermaine, I hear you talk about some of the ways that those disparities existed for even your family immediately. What I'm thinking about is gender bias and racial bias and just bias in general, and how that can impact the care quality, the diagnosis, and overall healthcare outcomes in women. And Dr. Johnson, in this space, I'm wondering if you can add some context to this.
Yes, absolutely. So I think it's important that we all share the same different definition and understanding of what bias is. And bias, actually, as we are elevating the importance of awareness of our implicit and unconscious bias, has gotten sort of a negative rap. And bias in and of itself is not necessarily, it isn't negative, right? We all have biases. And if we simplify what bias is, what we're talking about is preferences and assumptions.
And we need those, right?
Yes, we need those, right? It's incredibly important for us to be able to make decisions based on that, right? So it gives us this starting point or anchors us in, where to start with information, and then we sort of move from there, becoming more open-minded and curious. So bias by itself isn't negative. We have them. It's really about your self-awareness, right? And your ability to understand the biases that you have, where those biases have come from, and then so how we make decisions based on that. So bias alone isn't negative, but it can be dangerous if we don't recognize them and recognize the impact that it can have, especially if our biases are rooted in negative stereotypes or just inaccurate information, right? So bias in healthcare can result in poor treatment. It can result in providing some inaccurate diagnostic information. It can impact the way people navigate the care experience and reduce folks seeking healthcare. So if I, for example, have assumptions about what it means to be low income, and I may have some negative beliefs and assumptions about that, about what it means to live low income, then I can make some troublesome decisions as a result of that as a healthcare provider. And that can affect your diagnosis and treatment decisions, as well as forever impact how you see the healthcare system. So it can be dangerous when we aren't aware of those biases and infuse that into the care experience. There was one study by the National Institute of Health, and they looked at how providers perceived pain. And this is really important. You hear this sometimes from people of color that, the doctor didn't believe me when I said I was in pain. And this study, they found that providers actually had difficulty identifying pain in the facial expressions on Black faces compared to white faces. And if we are making judgments based on that, then that can affect the treatment that you provide, whether or not you're going to treat the pain. So that's just one example of how that can show up.
Wow. So, so you make me wonder about how much of this is historical bias and how much of this continues to infuse itself in our current day healthcare system. So if we look at the historical context of health, the quality of healthcare, and how healthcare presents itself, how much of in what ways do you see history repeating itself today? And this is an open question for any of you. And this is a spinoff of a couple things that Dr. Johnson said, because you piqued my curiosity. We know that the bias is there. We know that, historically there's these myths about Black pain. We know historically there's testing and treatments and stuff that have been designed based on simply being, non-Black or being white, or in some space or in some way like that. So when you think about that, I'm just curious, in what ways do you see history repeating itself when it comes to the diagnosis and overall healthcare outcomes?
I would say, I would just sort of flip the question and say, when does history not impact when we think about our history, particularly here in the United States, and how racism was formed, and systemic racism, and how that has just impacted everything. It's how could it not, right? So I see it everywhere, in every system that we have, and it's going to take a lot of work and intentionality to really disrupt those systems, and really have an anti-racism approach to the way that we do our work.
Mm-hmm. And what I hear you say brings up and reminds me of something that Tina said, bringing to light those things such as social determinants of health and how they impact people, so that, and as practitioners, to just have that awareness so that you can provide the appropriate treatment plans. So, and this is for any one of you that would like to answer. If you could focus on one area to eliminate healthcare disparities, what would it be and why?
So I'm going to speak at least from my personal loves and the things that I am most passionate about, and that really is perinatal and postnatal care. It tends to be one of the most vulnerable points in our lives when we are pregnant, and having access that is culturally responsive, that is quality throughout the entire experience, where you see people that look like you, that understand where it is that your story comes from, and how vulnerable it is to be in the care of someone else as you're bringing life into this world. And then even going into that fourth trimester, that really at the end of the day is still a part of that pregnancy journey, and how important breastfeeding and infant care and reducing the postnatal mortality rates for both mothers and babies is somewhere that I would start. And I think one of the biggest ways to do that is, again, having healthcare, able to see healthcare providers and staff that looks like them, and providing that care that is, again, just culturally appropriate, and able to make those connections in such a way that we're providing that high quality care.
Wow. And we know that there's such a gap. And so we really have to start young, right? Second, third grade, rearing the children up to see that they can be these practitioners in these spaces, so that we can grow that capacity. And so, Dr. Garcia, even though while we have such smaller numbers of women of color in these critical spaces, what is some ways that we can begin to work with our practitioners who may not reflect the patients that they're caring for?
I think the biggest thing is helping empower ourselves and know always say no and take a pause to kind of figure out what exactly is going on. If I don't understand something, digging further to really make sure that I understand what's going on, what the context is. In at least in pregnancy, one of the biggest pushes has been for doula cares. Having a doula at your bedside, having that advocate there to help you navigate all of those difficult questions. And even hearing from some of our moms saying, it was amazing that my doula asked some of the questions that I didn't even think of at the moment. So it's finding those ways of empowering yourself. Bringing in your family. I will be completely vulnerable and admit that as a child of first generation immigrants to the United States, and my mother learning English at the same time that I was learning as a toddler, I remember going into all of her appointments and having that family be there to help. Integral and important, and understanding that is okay, that you are allowed to bring those people in to help support you and to help you navigate this system that can be very overwhelming and very scary.
Beautifully said. Thank you for that. Dr. Johnson, chime in.
Yeah, when I think about this question, I actually would focus on something that isn't directly about healthcare. I would focus on more of a root cause. And to my point earlier, when we think about how racism was created, why racism was created, one of my favorite books. I'm drawing a blank on the title of the book, but Ibram Kendi has a book, and he talks about the origins of racism, um, and he outlined it perfectly. We recognize that the purpose of it was to create this hierarchy of human value, and one of the ways to do that is to create the haves and the have-nots. And so I would focus on closing the gap on economic disparities and educational disparities, which I really see as a key driver to a lot of the other factors or things that drive some of the issues in our institutions and in our society, regarding inequities and healthcare disparities. So I would focus on closing that gap. How do we provide fair and equitable access to education, quality education for everyone, regardless of what neighborhood you live in, right? Because it kind of starts there, right? So if your education system, you receive money based on the community that you live in, well, of course, right, it will impact the quality of your education, and that can follow you on right down a path of poverty, and not it isn't prescriptive, right? So it isn't for sure, but it definitely doesn't set you up in the best way for success going forward in your life. So I would focus on some of those root causes that can close some of those gaps, which then I think in turn can help impact some of those healthcare disparities.
Well said. Jermaine?
Sure. So yes, I definitely agree with our previous speaker. Well, I agree with both speakers. There's so much work, right, to be done, and but I think overall, we have a systemic problem in our country, and it is racism at the root. When you think of institutions that were birthed or established in a certain era, then it was baked into that concept of racist practices. And certain people were not in mind during those times. And oftentimes, those systemic things still manifest themselves today in many ways, with the lack of representation, that was already spoke about earlier. And I think if you lead with the lens of eliminating racism, you fix and align all the other isms that exist. And that doesn't matter what organization or institution, whether we're talking about the medical field or whatever, if you start with racism, you can eliminate all the other isms, because the reality is that many other marginalized groups have had their day, but people dealing with racism still have not had their day, still have not received the promise of the 40 acres and a mule. And so the reality is, if we start with racism, it really creates that fairness for everyone, the true equality. You know, everyone wants to jump on the bandwagon of, I mean, what hospital don't have DEI, diversity, equity, inclusion groups or teams and what have you? But this is not a cliche. This is not a trend. This has to be transformative. This has to be from the top down and baked into institutional practices. This has to even be governed from the board level, so it's baked into the policies and procedures of the hospitals, so that things can really change for the better. And then it will create that fairness, that equality for not just women and women of color, but it will create it for all.
So it sounds like to me, when I sum up everything that Dr. Garcia has said and Dr. Johnson and what you were saying, it sounds like you, versus healthcare equality, we're really looking for healthcare justice. And that's where the systems change and they are just and fair for each person that walks through those doors, that is hoping to experience um, the health access to the healthcare that they need. And that's such a powerful place. I do want to also go back to something that I heard Dr. Garcia say, and that was that empowerment piece. Oftentimes when I think about some of the ways that you can eliminate healthcare disparities and in places, and I think this goes along with what Dr. Johnson was saying too. Um, is just the empowerment piece, is being able to know that you own your own health care. And so when we think about the fact that we own our own health care and we should be empowered or feel empowered, what stands in the way? This is not on the question list, but it was triggered by a couple things that you said. What stands in the way of participants of healthcare systems feeling that empowerment?
Well,
Oh,
go ahead. Go ahead. Go ahead, Dr. Garcia, you first.
honestly, it's power. And it's the power that people don't realize that they hold when they walk in the room. We've got degrees, we've got years of experience, we've got status, we have power roles that a lot of people don't even realize, that when they come in, they're automatically disempowering another person by the words that they say, by the way that they phrase things, by the way that they question people. So I think power in itself, and those that hold power are the ones that can take away someone else's power, or we can recognize it and help uplift another person's power.
I love that. And really that power, we have given it so much value, right, in our culture. And even for practitioners, and I'm one of them, right? So I'm a practitioner, and we feel the need to be right, and I think that can feel disempowering to people, to our clients and patients that come into the care system. And for us to really move beyond that, we're going to have to abandon the need to be right and embrace the opportunity to learn and grow from our patients and clients, and let them be in charge of their health, right? So we come in with, educational background and what we've learned about life, and we want to own that, and there's a lot of ego in that sometimes. And I think for us to move beyond that is like to just abandon that need to have power over another person, and not feel threatened by our patients and our clients owning their health choices and telling us what's important to them, and spending more time in that learning zone than in this I have to perform and posture and know. I think though that presents as a barrier, and it makes it really uncomfortable and threatening to people who come to us for care.
And also, some of you may be familiar with the story, the book by, I think it's by Spencer Johnson, Who Moved My Cheese? And to your point about that whole power thing, it is a power struggle where people, they fear this idea that they will lose power. And the reality is power needs to be leveraged in order for us to really level the playing field to create, equitable practices for everyone, better healthcare practices for everyone. The reality is here in America, we can look at other countries and see where the healthcare system is significantly better than what we're operating here. But we like to deem ourselves to be, the top innovative individuals in America, but we're doing everything backwards, and we're not doing everything with this equitable and fair lens where everyone can share. And so it's this idea of, again, holding on to power and not wanting to let it go. So I think it's important that in order for this to work successfully, it certainly has to be that trickle down effect where it comes from the top and it begins at the top and they really buy into it. And then it makes its way down and bakes into the practices that we would live into every day. That's the only way it will work. It can never be a DEI committee. It can never be an I can't tell you how many anti-racism teams and diversity, equity, inclusion groups I have been a part of until everybody burn out and tired, resign, and go on to something else. And it doesn't work that way. They may have all of the knowledge that it takes in order to shift an institution to make it better. But if it's not something that everybody buys into, especially from the top, it would never work.
Thank you. Thank you. Thank you. Wonderfully said, and lots of gems in that space. And gosh, if we could duplicate each of you in your respective roles and then expand you out into other spaces, it feels like a place where, as a Black woman, I wouldn't have the hesitancy or the extra preparation of, okay, putting on business clothes when I go to my appointment, making sure, timing, adjusting my language, coming prepared with notes, so those are all some of the things. And I ask that question because that is, I know I have power and I am empowered to manage my healthcare. And I also recognize that the power struggle exists, especially if my practitioner doesn't look like me. So hopefully there are some nuggets that have been grabbed from this discussion, this conversation around that, that some of the women in our community can pull on. So when they are going to see their pediatric specialist or someone about their labor and delivery, or even mental health or behavioral health supports. Dr. Johnson, I'm thinking perhaps there's something that they could have pulled from this conversation to help them feel empowered in that space. So as healthcare practitioners, What is the most fulfilling part of your job? And I would love if each of you could chime in and just share, like you operate in different aspects of our healthcare community. You support unique groups of individuals. Where's your joy? What's filling your bucket? What's the most fulfilling parts of your job?
I'll start. So, as an educator, I just love listening.
I can go.
I love listening to
So
people.
at least for me, one of the most
Oh, let's go, Tina. I heard Tina start to speak. Let's go ahead and mute and let Tina jump in.
So my most fulfilling part of my job, it just as an educator, is just getting a gauge of where people are, right? I work in nutrition education, and I'm helping people make change. And we all know that change is very challenging. And so we all realize that, you can't just snap our fingers and everything's going to be perfect. And so just listening to people, getting a gauge of where people are in their power in their healthcare, right? Where are they at? What changes are they wanting to make? Listening to them is by far my most satisfying part of my job, and meeting people where they're at. I'm more in the community now. So in Battle Creek, I'm going around to different site locations and just listening to people and understanding where maybe they're addressing some of their needs in gaps in education or health topics. And so I very much enjoy that as part of my job, just kind of taking their voices, the community's voices, and hopefully trying to do something with that. Maybe I'm not always that right person, but bringing it to the table for somebody else and working to increase the healthcare of our community.
Beautiful. Dr. Johnson, you want to jump in?
Sure. So I'm a mental health practitioner. Even though I'm a leader, I love doing therapy. And so I make sure that I continue to do that because I get the opportunity to see people in rare form. And I really mean that in the most meaningful way possible. It does something for me to work with people and get to um, experience them authentically. And I learn something every single day about people in my work. And that is the biggest joy for me, right? Is that I get to see people and I get to see who they really are, the unpolished version, right? The mask is off, and that they trust me enough to share some of the most intimate moments of their lives, and that I get to do that. So I love to be able to do that.
Hey, Dr. Garcia.
At least for me, one of the things that I love the most is making connections with patients and their families, and trying to gain that initial connection with families that have just brought in a new life into this world. I'm incredibly passionate about breastfeeding as well, and so for me, one of the most exciting things is really helping families find those outpatient connections, whether it's continued lactation services through the hospital, what our community organizations are that can help provide care and support, because it does take a village. And so I love really helping support those new families to find what it is that might help make things a little bit easier and help be more supportive for them as they bring their new babies into their homes.
All right. I have one question, another question I want you to think on. So you've shared what's your most fulfilling part of your job. what is one piece of advice specific to the work that you do that you would tell women to lean into to ensure or to even set themselves up for um, for supportive healthcare, if you will?
I would encourage women um, to not be afraid of their voices. Sometimes I think as women, we're trying to hold all of these expectations about what it means to be a woman. I don't want to be too aggressive, and I don't want to be too passive. And so we have all of these, this end of the spectrum and that end of the spectrum. And somewhere in there, sometimes we lose our voice. And so I would encourage women to elevate your voices and don't be afraid to interview your practitioner. Right? Like I'm all about like interviews. I welcome it. When clients call and they say, I want to know what you know about this and what you know about that. And I love that. So I would encourage you to interview and feel free. And if a person is not open to that, that probably gives you your answer.
Dr. Garcia?
I mean, I absolutely have to echo what Dr. questions. Don't be afraid of our voices because we hear quite often, you're too loud, you're too vocal, you're too verbal, you're too much. But at the end of the day, that's the way that we have to make sure that we take care of ourselves. So asking those questions, ask those follow-up questions, ask that third clarifying question if that's what you need to do, but make sure that you are speaking up, that you are using your voice. Even in pediatrics, definitely interview. You want to make sure that you've got connections with people that feel right and that you have a mutually beneficial relationship. And again, that you're going to be comfortable, because you want to make sure that you have relationships that last for a while, and that you're going to feel seen and heard, and that your care is going to be um, the most important thing that we can affect.
Tina?
Yeah, I'm definitely going to echo their sentiments. I was going to say, like, be your own healthcare advocate. And just like Dr. Garcia was saying, asking all those clarifying questions, no matter how many questions it takes, realizing that you have to understand, the information that is being given to you or the diagnosis that's been given to you. If there is that expectation that you're going to want to take care of that, you have to fully understand it. So being your own advocate, asking those clarifying questions, and, interview process, but, maybe even getting a second opinion, and getting additional information in that way.
Jermaine, I see you thinking. I'm wondering what you might add to this.
I'm just actually reading some of the comments of questions that's in the comments that I'm thinking about responding to. That's all.
Okay. All right. I appreciate you allowing me to drill you with questions and to really just absorb from your vast experience, from your knowledge, and from the care that you have for the patients you serve, from the way you show up in our community and impact the women within our community, and really also your distinct cultural representation, which is, I don't take it lightly because it's hard to find women of color in the professional spaces that you hold. And so, what I love about this is not only are we celebrating women on this panel, we are also celebrating uh, practitioners who are women of color that provide a wide range of support within our community, and also teaching us ways to take a hold of and to really own our own healthcare. So thank you for that. I'm being told that there's quite a few questions from the audience that we should go through. So I'm going to go over here to the comments. And here's the first question. It looks like from Tanisha Dungy. Moving forward, what can we do in the short term to take steps in tackling these disparities as a practitioner and as a patient? And this is kind of drives you off of the question that you just answered. But if you can add a little bit more context to what you have said, if it's appropriate.
So for me personally, as a dietitian, I think that it is important for me as a healthcare professional, and also a white woman, right, to be continually educating myself on the cultural relevance of nutrition education and the foods consumed from different populations in our community. And, that would be something that I do and will continue to do to take steps in tackling healthcare disparities, because we know that nutrition education has to be completely relevant. Otherwise, there's going to be no takeaway and change to manage a disease.
Well said.
I would say notice. To move forward on healthcare disparities, you first have to know that they exist. And so I think one manageable and practical way or short-term step would be to collect data and stratify and notice disparities and just get curious about them, right? Notice the disparities and get curious.
And I would say that it's important to take baby steps. Take baby steps. You don't try to flip a system that have been this way for hundreds of years and try to do 20 things. If you're doing one thing at a time, half of one thing at a time, if you are eliminating one issue that creates a disparity, you have moved a chunk of that iceberg. We know the iceberg concept, that there's more than meets the eye, because you only see what's on the surface, but what's beneath is what's greater. So it's going to take some time, but baby steps.
So it looks like our next question would be, what has been successful so far in eliminating disparities in the healthcare field? Thank you for your question, Erin.
Well, what I can say to that, I'm not a practitioner or a doctor, but I would just say that, so for myself, who's traveling an exhibit about my aunt, the late Henrietta Lacks, who died in 1951 of cervical cancer, and those cells were taken without her permission or consent or the consent of family members. And of course, during the 50s, that certainly was a time that was certainly in the medical field not favorable for Black people. And there was not many hospitals during that time that even served Black patients. And so I would say, to help eliminate what's been successful in eliminating disparities, the conversation about Henrietta Lacks, because of what happened with her, it was the conversation that evolved around Henrietta Lacks, this Black woman, that really established the idea of ethic teams and the idea of patients' right. And so again, it took someone speaking up, initiating the conversation in order to implement that small change. It's not perfect. There are still issues, but it was something that have helped all by the establishment of ethic teams and patient rights.
I also wanted to go back and hit on what Dr. Johnson had mentioned as well, insofar as data. It's hard to ignore the data when you have it. And I think that's been one of the most impactful things for people and systems to look at, because it's very easy to say, oh, well, yeah, okay, here in the US, but here in our community, like that's not actually happening here. But when you look at that data, you stratify it based on, and I'm going to use that terminology, the SOGI data, where we're looking at sex, gender, orientation, income, and you're able to look at all of that data. It's much harder to ignore at that point, and it really helps people in systems that are functioning the way that they were designed to function. But it really allows for the people to turn around and say, oh, this is not okay, and hopefully start making those changes.
Yes, I would say what has been successful is bringing healthcare to the community. Um, I love how creative we are getting and showing up in community spaces, and then what that's doing is we're learning from communities, and we're using more of those community based and adaptive approaches to those evidence based approaches. So I think bringing healthcare to the community has been successful.
And was the pandemic a big catalyst for that, Dr. Johnson? I feel
Yes.
like before that, we didn't have this big community-based healthcare approach. The pandemic hit, and we
Yes.
needed to meet the community where it was, specifically the Black and the Brown communities who were not already did not have that trust, had gobs of distrust.
Hmm.
And so we flex. And if we can flex in that way and come into community
Yes.
spaces and introduce ourselves and talk about our desire to improve health, how we want to look at your social determinants of health and have and reverse those so that your
Yes.
healthcare outcomes are improved. Isn't that such an interesting thing?
Yes.
That
Yeah, I mean, like it is one of the benefits of the pandemic, right? I mean, we got rid of some of our rigid ways of how we believe healthcare could only be delivered, right? And so it was an unexpected experiment that happened, right? Because we had to deliver care that way, and we learned that there were some really effective ways for us. Telehealth, for example. And sure, it's not perfect for every situation, but it opens up options, right, for people. And so I think that you're right. The pandemic really just allowed us to get creative, deliver care in homes and community centers. And so, yeah, absolutely.
and that's what they got that data,
Yeah.
Dr. Garcia, which triggered all of that movement. Like no walls in healthcare. We got the data. We know where we need to go, and I love it. And I hope that as healthcare continues, that we don't get back into that rigid healthcare form, and that we continue to stay flexible in that way, so that we can continue to provide. Um, Exceptional healthcare for our communities, um, to advance them and to empower them to be healthy and health partners in their healthcare experiences. I thought there was one more question up. It looks like it disappeared, but I still see it. So we have like 6 minutes for you to talk about um, your pathway. So, what led you to healthcare in your specific areas? And what was your inspiration? I'll invite you in. How about that? Tina, you're in the middle. How about if you go?
So, who doesn't love to eat, right? So, food is my passion. So, why not make a career out of it? I wish I had a great story. I don't. I like to cook. I think food is my love language, right? I care for people and hear people in that way. And so I love to help people with food. Food makes the world go round. It does. It brings us all together, and it can be powerful as part of a treatment option. And so I just love to help people make those changes and be a part of that.
Healing and power. That's what I get. Of course, there's deliciousness, but it's also meant to heal and empower the body. Yes. Dr. Garcia?
At least for me, I grew up with two parents that had very complex medical histories. My mom has a form of sickle cell and has had 3 different types of cancers in her life as well. And my dad was diagnosed with lupus when I was 5 years old. So going in and out of the doctor's office, and I wanted to be a helper. I wanted to be one of those people that helped support people that were scared, like my parents were when I was growing up. And I teased that pediatrics was the one thing that I could not shake in medical school, because I went into every single one of my rotations going, I'm not going to be a pediatrician. I'm going to fall in love with cardiology or pulmonology, and I could not love anything the way that I loved pediatrics. I love kids. I love connecting with children and their families, and yeah, that's what led me here.
We really appreciate you, pediatrics, because my son also has sickle cell. He's 30 now, but they loved my son so much. They held on to Deshaun even until he was about almost 19. They held on to him because he was so used to them being the ones that treated him, supported him through his journey with having sickle cell. And so it has been a helpful journey to have that support from the pediatrics. Just wanted to mention that.
Beautiful. Dr. Johnson?
Yeah, my answer is really spiritual. I truly feel called to do what I do as a mental health practitioner. I tried to run away from it several times and I couldn't get away from it. And I was in an interview for a different program, and the interviewer shared that she was receiving a revelation from God that I was called to go into mental health. And I didn't question it from there. So my answer is spiritual, and it was the best decision that I've made, because I really truly do feel a spiritual connection to people, not religious, just connected to people in general. So that's my path.
And that's beautifully said from all of you. Because what I know for sure is you didn't accidentally arrive at what you are. There was some passion and love for people and your service to others that got you to where you are. So what a beautiful sharing. What a beautiful way to round out this conversation. Um, to round out this Women's History Month, it's an honor to have Jermaine Jackson. I have seen the Gila exhibits, and to really be a recipient of the power of her cells and myself, and then to also be able to share space and be colleagues with Dr. Garcia, with Tina, and Dr. Johnson. I'm going to invite Jade back into the conversation to close us out, but I appreciate being here with you all today.
Thank you all. Thank you, panelists. Thank you, viewers. Just thank you for your insight. Yeah. Don't forget to look at our Willard Library calendar and schedule. You will be seeing Tina again next week, as well as the weeks after for her program. on, I can invite Tina on just to give a little bit more about that. It is a 6-week program that's registered, registration required. So, Tina, just a little bit about that.
Thanks, Jade. Yeah, so I'll be teaching. It's called Fresh Conversation. It's a nutrition and physical activity 6-week class. Registration is required and open on the Willard Library website. It is targeted to older adults, preferably over the age of 60. There will be some taste testing of various foods and recipes throughout that, so we hope you join us.
Thank you. And to all, thank you for tuning in. Have a wonderful evening.
Thank you all. Take care.